Thank you, Mr. Chairman, for your kind introduction. Good morning, ladies and gentlemen. This is Seung-Yong Shin, Jung University Hospital. Today, my topic is left atrial appendage occlusion under imaging guidance, T versus eyes. Left atrial appendage have very complex and various shape and size. In order to close left atrial appendage ostium completely, appropriate imaging support is highly required. At the beginning of left atrial appendage occlusion procedure, operators chose Transesophageal echocardiography. In terms of thrombus detection, 2DT was very useful, but size measurement of 2DT were poorly correlated with real size for device selection. In right panel, our experience was retrospectively analyzed in terms of agreement between 2DT measurement and final device size selection in patients with complete closure in the follow-up TE. Because of limited value of 2DT, we can consider 3DT. However, 3DT guided left atrial appendage occlusion procedure requires high physical burden of the patient and it requires a long procedure time. Due to too many images in your toolbox, it may take too much procedure time. Therefore, we need to minimize intra-procedural steps. Our next imaging modality was CT. Through 2D and 3D imaging measurements, we were able to become more confident in size determination. But it was not enough to replace pre- and intra-procedural transesophageal echocardiography. Therefore, we tried to investigate 3D models' usefulness. Thanks to Dr. Joe's nice works, we could make a 3D left atrial appendage model with high accuracy. With this model, we could grasp individual left atrial appendages, anatomical characteristics, and we could simulate and plan procedure with no risk and no time limitations. By using real occlusion device, we retrospectively investigated 3D model simulations usefulness. As you can see in the middle column, 3DP model was really nicely worked and its agreement was very good. Compared with 2DT measurement in right column, you can clearly find the difference between the two modalities. In short, within pre-procedural steps, in terms of measurement, CT with a 3D printing model was superior to transesophageal echocardiography. Then let's go to intra-procedural steps for imaging guidance. Nowadays, intracardiac echocardiography is frequently used in many kinds of structural intervention: CTI ablation, LV ablation, ASD closure, appendage closure, and so on. Its range of application is rapidly expanding. Last ENCORE meeting, one present told that ICE means I can't see. Some operators said that ICE has low imaging resolution. I would like to ask you if ICE has lower resolution than TE. These images are acquired in the same patient with ICE and TE in the same time. Can you guess which one is ICE, right or left? Left column is ICE. Transesophageal echocardiography proof and ICE catheter is placed. And ICE catheter is introduced in the left atrium via transeptal puncture and is placed near the LAAO appendage ostium. By placing and manipulating like those cartoons, eyes can guide the whole process of the procedure from transseptal puncture to device delivery and peri-device leakage verification. I'd like to ask you one more time. If eyes can provide similar or better imaging without general anesthesia and minimalized risk, which will you choose between eyes and TE as an intra-procedural imaging guidance? I will show you one of my cases in which eyes-guided left atrial appendage occlusion procedure in the presence of left atrial appendage thrombi. In right lower panel, pre-procedural transesophageal echocardiographic image, you can clearly see LA appendage thrombus with high mobility. After 6 months anticoagulation, thrombi persisted as shown in the IC image. At the same location, this is upside down image. But the thrombi became smaller and it has no mobility. Therefore, we decided to perform procedure by no-touch technique. In order to avoid the risk of thromboembolism, we exchanged delivery sheaths outside the left atrial appendage, and the device was partially expanded state. It was introduced in left atrial appendage and fully expanded inside the left atrial appendage. And finally, the peri-device leakage was not observed after the procedure. By applying intracardiac echocardiographic guidance, patient's left atrial appendage was successfully closed without any trade-off. Another case showing advantages of eyes. Patient's left atrial appendage was divided by prominent septum. With the first device, the peri-device gap was more than 20 millimeters. Therefore, we decided to implant another device. Device delivery was finely controlled and guided by intracardiac echocardiography, and with just 2 attempts, we success to introduce the device. And patient's left atrial appendage ostium was completely covered with 2 occlusion devices. In terms of transseptal puncture, intracardiac echocardiography can visualize interatrial septum and left atrial appendage in the same plane. Therefore, we can finally verify our transseptal puncture site is good for device delivery or not. On the other hand, transesophageal echocardiography cannot visualize interatrial septum and the left atrial appendage in the same time, in the same plane. Let's summarize advantages and disadvantages of eyes. Eyes can provide similar imaging resolution and diverse viewpoints, but it requires anatomical insight within a given catheter location. When compared with eyes and without eyes procedure in our center, there were no significant differences between baseline characteristics, and by applying eyes, there were no significant differences in terms of procedural result, and we could perform left atrial appendage occlusion procedure without general anesthesia and in shorter time and with less radiation exposure. This is another report supporting routine eyes use in the US. They compared eyes and transesophageal echocardiography in left atrial appendage occlusion. There were no significant differences in terms of procedural outcome, event rate, procedure time, net procedure time, and radiation exposure, total cost, and so on. Eyes is equally useful in left atrial appendage procedure without any trade-off. Ladies and gentlemen, this is my conclusion. ICE is becoming a standard modality in structural intervention, including transseptal puncture or not. Although ICE can provide substantial information, but anatomical understanding and careful procedure planning is necessary and is critical to procedural success. With organized use of ICE, appendage occlusion can be performed with minimal invasiveness and maximal safety and efficacy. Thank you for your attention.